This is part 2 of chapter 23, the respiratory system. We'll learn about pulmonary ventilation, the process of breathing. Gas molecules diffuse from regions of higher pressure, which means higher concentration, to regions of lower pressure or lower concentration. This is the rule for gas exchange. There is always a concentration and a pressure gradient, and we always go from higher to lower pressure or from higher to lower concentration. This what will regulate the diffusion of oxygen and carbon dioxide between the alveoli of the lungs and pulmonary capillaries, or between systemic capillaries and the tissue cells, as we learn in details. Ventilation or breathing is made possible by changes in the intrathoracic volume, the volume inside the chest cavity. The movement of air between the atmosphere and the alveoli consists of inhalation, which is an active process because it involves contraction of specific muscles, and exhalation, which is a passive process because it only involves recoil of the muscles, relaxation of the muscles and recoil of the lungs. The volume of thoracic cavity can be increased by the actions of the diaphragm, which is the main muscle of inhalation, and other muscles of the chest that we'll learn about in details. Let's see how this takes place. The atmospheric pressure is around 760 millimeters mercury at sea level. At rest, the diaphragm is relaxed, and this is how it looks like. It's dome-shaped. Alveolar pressure is 760 millimeters mercury, and the intrapleural pressure between the two layers of the pleura is around 756. Let's see what changes will take place during inhalation. The diaphragm will contract, and when it contracts, it will become flattened. This means we have increase in the intrathoracic volume. And the general rule for gases that the pressure of a gas in a closed container is inversely proportional to the volume of this container, which means the bigger the size of the container, the lower the pressure of the gas inside this container. It has a more wide space to go through. So if we look at here, the alveolar pressure will go down. Instead of 760, it became 758 millimeters mercury. Same for the intrapleural pressure. The atmospheric pressure didn't change. So air will be sucked to the inside. It will go from higher pressure to the lower pressure inside the lungs. What about during exhalation? The diaphragm will relax. It will go back to its normal dome shape. The alveolar pressure will increase because we are decreasing the size of the container, which is the lungs. So pressure will increase in these lungs again, and air will leave the lungs to the outside. So it all depends on changes in the intrathoracic volume. Certain muscles help in inhalation and others will help in the process of exhalation. We have normal muscles and we have accessory muscles that will help in forced inhalation and exhalation. We need to know the muscles in each group. The main muscle of inhalation is the diaphragm, plus the external intercostal muscles. And we've seen all these muscles in AMP1 before. Accessory muscles of inhalation include the scalenus, sternocleidomastoid, and the pectoralis. We'll see more of these muscles in next slides. Muscles of exhalation. The normal regular exhalation is a passive process. So we have only muscles that will assist with forced exhalation, like the internal intercostals, the internal and the external oblique muscles, transversus abdominis and rectus abdominis muscles. So actually it's internal intercostals plus abdominal muscles. The recruitment of accessory muscles will greatly depend on whether the respiratory movements are quiet or forced. As we just explained, we have muscles that support the normal quiet breathing and others that will support the forced breathing. Let's understand this mechanism. During normal quiet inhalation, the diaphragm and the external intercostals will contract, while during labored inhalation, the sternocleidomastoid, scalenus, and the pectoralis minor will also contract. We need to know the muscles responsible for each group. During normal quiet exhalation, diaphragm and external intercostals relax. So this is a passive process. It's just the relaxation of the diaphragm and the external intercostals. While during forceful exhalation, the abdominal and the internal intercostal muscles contract. So the accessory muscles of exhalation only contract during forced exhalation. In contrast to ventilation, respiration is the exchange of gases. So ventilation is all about breathing, while respiration is all about gas exchange. And we already mentioned in the first slide that we have two types of respiration. External respiration, or the pulmonary one, this is a gas exchange between alveoli of the lungs and the blood. The alveoli will give oxygen to the blood and will take away carbon dioxide. This is the alveoli. It will give oxygen to the pulmonary capillaries and will take away carbon dioxide. While in internal respiration, at the tissue level, it's gas exchange between systemic capillaries and the tissues of the body. The systemic capillaries will give oxygen to the tissue cells and will take away carbon dioxide to make the cells rid of waste products. How we measure ventilation? It can be measured using spirometry. This is a device used to measure ventilation. All the new spirometers are used to measure ventilation, and they will create a spirogram, something similar to the EKG or the electroencephalogram. The same way, we have a device connected to a computer that will trace the activities in the lungs and give us an idea about the different volumes and the function of the lungs. We have different volumes here that we need to know the definition of each. Tidal volume. This is the volume of air inspired or expired during normal quiet breathing, which is around 500 milliliters. So in other words, it's the amount of air coming in and out of the lungs, in and out. Inspiratory reserve volume. This is a volume inspired during a very deep inhalation. Like if I ask you to take a deep breath, this is the maximum volume that can come into the lungs, maximum volume of air that can come into the lungs. And it's around 3,100 milliliters. Expiratory reserve volume is the volume expired during a forced exhalation. Like when you're puffing air out, the maximum volume of air that can go out of your lungs when you're breathing forcefully. And this is around 1,200 milliliters. Vital capacity is all the air that can be exhaled after maximum inspiration. Like if I ask you to take a deep breath and then exhale as forceful as you can. How we calculate vital capacity? It's the sum of the inspiratory reserve, tidal volume, and the expiratory reserve volumes. We need to remember this equation. The last volume here that we'll define is the residual volume. This is the air still present in the lungs after a forced exhalation. This residual volume is a reserve for mixing of gases, but it's not available to move in or out of the lungs, only for gas mixture. This is a graph of spirometer showing the volumes and capacities. Let's see the tidal volume. This is the tidal volume, which is around 500 milliliters. This is the inspiratory reserve volume, maximum air you can get in. This is the expiratory reserve volume, the maximum volume of air you can get out of your lungs. The three together, as we mentioned, are the vital capacity. And the amount that stay in the lung after forced exhalation is the residual volume. All of these together form the total lung capacity, the total capacity of our lungs, how much air can be totally inside our lungs. We're good? Any questions?
No question.
No question.
The next topic we need to know about is ventilation perfusion coupling. This is a coupling of perfusion, which is blood flow, to each area of the lungs to match the extent of ventilation, which is airflow to the alveoli in that area. In the lungs, vasoconstriction. Vaso means blood vessels. Constriction means narrowing. In response to hypoxia, low level of oxygen, will divert the pulmonary blood from poorly ventilated areas of the lungs to well-ventilated regions. So whenever we have low oxygen level, the blood vessels will undergo vasoconstriction to direct blood. It's like that traffic light. It will open and close, but it will direct this blood into the areas that are well ventilated. And this response is specific only to the lungs, because in all other body tissues, hypoxia will cause dilation of blood vessels to increase blood flow. So only in the lungs, we have vasoconstriction in response to hypoxia. All over the body, we have vasodilation in response to hypoxia. Other factors that affect pulmonary ventilation or breathing is the surface tension of alveolar fluid. It causes the alveoli to assume the smallest possible diameter, and it accounts for 2/3 of the lung elastic recoil. So this surface tension, not only it prevents collapse of the lung through the surfactant, but it's responsible for the elastic recoil of the lung. Surfactant, we already explained this a couple of slides ago. It's produced by type 2 alveolar cells. Normally, alveoli would collapse during exhalation, but the surfactant will prevent the collapse of these alveoli. So it will decrease our work of breathing. We don't have to do a lot of effort to exhale air out of our lungs. This is respiratory distress syndrome, and it's very common in premature babies. As I said, their lungs are immature, so they don't have enough surfactant to prevent collapse of the alveoli. They are born with breathing disorders. They have blue skin, labored breathing, grunting, and usually they need help with the respiration. Sometimes just oxygen, but most of the time we need to put them on a CPAP to give them extra help. Sometimes we inject surfactant even till their lungs are mature and they can breathe on their own without difficulties. It's more common in males too. It's more common in males than females. Other factors that affect the pulmonary ventilation is the lung compliance. What the meaning of lung compliance? It's the ease with which the lung and thoracic wall can be expanded, elasticity of the lung. The normal healthy lungs have a high degree of compliance due to elastic connective tissue within the lungs. So what would decrease this lung compliance? Many lung disorders like broken rib, diseases such as pneumonia or emphysema, decreased surfactant, all of these may decrease the lung compliance, and so they will affect pulmonary ventilation. They will make the process of breathing much more difficult with increased work of breathing. One more factor affecting pulmonary ventilation is diameter of blood vessels in the airways. The larger the diameter of the airway, the less the airway resistance, the greater the airflow. If we have a large airway, more air can pass through without difficulty, and airflow would be easy. This diameter of the airway is regulated by the autonomic nervous system, sympathetic and parasympathetic. Any condition that would result in narrowing or obstructing of the airways will increase the airway resistance. Air will find much more difficulty to pass through the airway, like cars passing on the highway at traffic time. It's much more hard to drive at this time. Diseases like this include asthma. This is number one that causes bronchoconstriction, narrowing of the airways. COPD, chronic obstructive pulmonary disease like emphysema, and chronic bronchitis, chronic inflammation of the bronchi. This will decrease airflow through the lungs. And we're done with part 2.